Excuse me, ladies and gentlemen, we now have our presenters in conference. Participation in this presentation is by express or written invitation of the AHA only. Unauthorized participants and/or any party that aids and abets such unauthorized participants may be subject to criminal and civil penalties under both state and federal law. Please disconnect from the call or log off of the webinar if the AHA did not expressly invite your participation. Please also be aware that each of your lines is in a listen-only mode. Throughout the presentation, if you would like to ask a question or make a comment, you may do so by submitting it in the Q&A pod on the Adobe platform. It is now my pleasure to turn the call over to Mr. Derek Mitchell. Sir, please begin.
Hello, I'm Derek Mitchell from the American Hospital Association's Institute for Diversity and Health Equity. Thank you for joining us today for our December Diversity Dialogue webinar, where we will highlight the Carol Boone Lewis Equity of Care honoree from Atrium Health, who will share their journey to hardwire health equity best practices throughout the organization while impacting social determinants of health in the community to support Atrium Health's mission to improve health, evaluate hope, and advance healing for all. With that, let me introduce our presenters. First is Dr. Kinneil Coltman. Dr. Coltman was recently the Vice President, Chief Diversity Officer for Atrium Health. While she spent her career in healthcare diversity leadership, she has recently transitioned into a new role at Atrium Health as Senior Vice President, Chief Community and External Affairs Officer. In this expanded role, she will be responsible for building a unified strategy to advance the well-being of communities by driving strategic alignment across community health, community engagement, and corporate responsibilities, diversity, inclusion, career development, and community workforce planning. This new alignment will leverage Atrium Health's initiatives and programming to improve health access, address social and environmental determinants of health, and advance health equity. Next is Dr. Alisahah J. Cole. Dr. Cole is a true Renaissance woman, a musician, a physician, a mother, a volunteer, and a leader are just a few words that can be used to describe her. Dr. Cole is the Chief Community Impact Officer and Interim Chair of the Department of Family Medicine at Atrium Health. She has responsibilities over health equity, community health, environmental sustainability, mobile medicine, family medicine, education, and research. With nearly 7,000 teammates and 13 million patient interactions each year, Atrium Health is one of the leading healthcare organizations in the Southeast and one of the most comprehensive not-for-profit systems in the country. And with that, I would like to welcome Dr. Coltman and Dr. Cole.
Good afternoon, everyone. Thank you, Derek, for that wonderful introduction, and thank you to the American Hospital Association and the Institute for Diversity and Health Equity and having us today. So again, as Derek mentioned, I'm Dr. Alisahah Cole, and I'm going to start our conversation today around some of the work that Atrium has been doing to really advance the mission around health equity. So just a little bit about Atrium Health. If you are not familiar, we are formerly Carolina's healthcare system, and we changed our name a few years ago. But within 24 hours in one day at Atrium Health, we have about 38,000 patient encounters, so one every 2 seconds. We are one of the largest nonprofit integrated health systems in the country. We have over 25,000 physician visits. We deliver close to 100 babies a day. And one of the things that I love about this organization is that we give away about $5.6 million a day in uncompensated care. And so I actually have the unique opportunity to practice in one of our community and academic clinics where I'm able to take care of community members who don't have any access to health insurance. And that is something that has been embedded in the fabric of our DNA at Atrium Health, given that we were founded as Charlotte Memorial Hospital, the county hospital for Mecklenburg County, many, many years ago. mentioned, we are based out of Charlotte, North Carolina. However, we now have facilities across North Carolina, South Carolina, and Georgia. So again, a fully integrated health system that covers a broad geographic region that includes urban, suburban, and rural communities. And for Atrium, as Derek mentioned, our mission is to improve health, elevate hope, and advance healing for all. And I think I've alluded to the for all part of our mission, again, being founded as the county hospital. This belief of taking care of everyone and anyone who comes through our doors is foundational to our organization. We did revamp our mission statement about 3 years ago. We were really intentional about these words, and I always like to call out the fact that we said improve health and not improve health care. And there was a reason for that. If you look at the research around what actually impacts an individual's health, and this is over 50 years of research, we know that clinical care, and as a family medicine doctor still practicing, sometimes I tell my colleagues this might be a little painful to hear, but the clinical care only impacts our individual health about 20%. And so when you really look at the other 80%, that takes into account different factors that include health behaviors regarding, the type of food that we eat or the physical activity that we we're able to get in, or the substances that we may choose to indulge in. That also includes socioeconomic factors that can span from education to employment to food and transportation. And then the physical environment, so really what's happening in the communities, in the neighborhoods that are, and in the home that our patients are leaving our doors and going back to. And so I always like to kind of think of this around there are decisions every day that each and every one of us make that has an impact on our health. And like I said, that aligns more closely to the health behaviors aspect of this graph. But in reality, there are also decisions and factors that are being made for you every day that impact your health. So if you live in a community that doesn't have a grocery store or doesn't have good schools or doesn't have access to gainful employment, often it's not at the individual level that someone is able to influence those decisions. So those are happening at a higher level. So I think if we really start to think about what is truly impactful in improving health, it's really imperative for our hospitals and health systems to be more intentional about that work. So for us, we started to look more closely at the social determinants of health back in 2016. We actually spent a year in conducting our community health improvement study, which you see on the screen. What this map shows you are the 12 social determinants that have been proven, again, in the literature over a span of about 50 years to consistently impact health. So those were things like paying more than 30% of your monthly income on rent or mortgage, or living in a crowded household, living in a food desert. We were able to take those 12 determinants and create a social index score, and we were able to get that information down to the census tract level. So what you see on the map is the dark red and the dark orange areas are the neighborhoods that have the highest social needs. We then overlaid some of our patient-level data, including diabetes, heart disease, obesity, unnecessary ED utilization, and readmissions. And what we found is that there was a significant correlation in higher rates of those variables in the communities that had the highest social needs. And so we really started to think about what is the work that we're going to do from a community health standpoint? How are we going to prioritize our efforts in the community, and how are we going to make sure that we are working with partners to be able to do that work? And at the end of the day, how are we also going to be able to speak to the outcome measures in addition to the process measures that most health systems and hospitals have been used to reporting out on? The interesting thing about this study, and the great news, is that this work was actually foundational to the state of North Carolina in setting up their Healthy Opportunities pilot. So this information is now available for every single county across North Carolina. But how do we take this information again and start to drive change, not just for our patients, but also for these specific neighborhoods? And I have given this presentation in multiple counties, in every county that you see here on the screen. And I often pose the question, is anyone surprised by where the dark red and the dark orange areas are? And I've only had, out of probably 500 presentations, one person ever raised their hand to say they were shocked. And I come to find out, because I had to go talk to that person afterwards, I found out that they had just moved into that county and was still kind of learning the lay of the land. So, you know, I posed the question to all of you. You probably could identify where some of these dark red and dark orange communities and neighborhoods are where you live. And if we intuitively know where these communities of need are, the question is, why are they still communities of need? And so I think all of us could argue that there's a moral imperative for us to do better by these neighborhoods, but there is now also a financial imperative for us to think differently as we're transitioning into a more value-based model of care. So we use this information to really set our strategic priorities for community health. We wanted to make sure that these were community-driven priorities. So we did a community-based participatory research framework in engaging with all of our community partners in every county. That included our patients, people who weren't our patients, all of our health departments, government, private business, nonprofit partners, education partners, to really see what were the issues that were driving concerns in each county. And I will say I was a little shocked at first that there were areas that were consistent across every single community that we served, regardless of whether they were, again, urban, suburban, or rural. And so that's how we selected our community health priorities, which you see in front of you. The other, I would say, a critically important piece of this work is that in 2016, we actually made the community work a system-level strategic priority. So enhanced community health and benefit in partnership with others is actually one of our 9 key strategic priorities for the entire system. So this was endorsed and supported not only by our CEO and our senior executive team, but also by our board. And that really helped to start drive infrastructure and resources to make sure that we were doing this work in a more intentional way. So just to give a few examples of some of our initiatives that we have launched since starting this work. As you saw on the previous slide, access to care was one of the areas that was consistent for our community members, and particularly when our community members said they wanted better access, it was always around 3 areas: primary care, behavioral health, and dental. So in Cleveland County, which is one of our rural counties that we serve, there was a situation that we have 2 hospital facilities in that county, both with emergency rooms, and we were at capacity in both of those emergency rooms. And there was a lot of unnecessary utilization that was happening, but at the time, our facility president was saying, I need to expand capacity in these ERs because we're just so overrun. At the same time, we were looking at some of the community level data, and we were recognizing that there's, and also comparing it to some ED utilization data, and we saw that there was a significant increase in children with asthma who were coming into the ER from a one elementary school, which was a Title I school in a dark red area. We then met with the school nurse and the principal and found out that she was sending a child to the ER once every 5 days. And often she was sending them by EMS because a lot of the parents worked outside the county and it was difficult for them to get back and get their child to the ER. And asthma was a big driver of, well, really the number one driver of her sending children to the ER. And when we started talking about, well, why are you sending them to the ER? Well, it was things like they ran out of their albuterol inhaler, or they ran out of their controller medication, or they didn't have an asthma action plan on file. And so we were able to embed virtual care in with the school nurse, that now children come in and she can connect back to a pediatrician, a local pediatrician office that is one of our facilities, and they can receive care right on site at school. So we've seen a 50% reduction in dismissal. We've seen a 77% reduction in ED utilization following their first virtual visit. And we've actually seen about a 24% increase in our pediatric visits in that office. And so there was some initial concern that if we're providing care virtually through the school, that's going to decrease our volume in the office. And in this case, we did not see that. We actually saw that there were a lot of kids that did not have a primary care home and got connected to our pediatric practice through the virtual school health program and started to receive their preventative services through our pediatric practice. So we are now actively expanding that program across our other rural communities where resources are often sparse. Another thing that we heard in regards to access to care from a primary care standpoint was also this notion around primary prevention and just education around nutrition and physical activity. So we have a very robust, long-standing partnership with the YMCA, and so we partnered with them to bring a mobile unit. We call it the WOW Mobile, Wellness on Wheels, and it really focuses on nutrition and cooking and physical activity. And then we also partnered with the American Heart Association around blood pressure control. So we instituted the Check Change Control program off the mobile unit, and we've had some amazing results. This unit is going into, again, communities that are often deserts in many ways, food deserts, healthcare deserts, employment deserts, and accessing community members that, quite frankly, still often have a mistrust of the healthcare system. So we've seen some dramatic improvement in blood pressure control and weight since we launched this program in January of this year. And we've also started to see an uptick in the establishment of community members who previously did not have a primary care provider with primary care providers, which has been a great thing to see. As we were doing this work, again, we realized that it's one thing to have the community level data and the neighborhood level data to help drive what some of our outwardly facing community initiatives and programs should be, but we didn't actually have our own patient level data when we first started this work, and we felt that was critically important for us to be able to provide help and resources in that face-to-face interaction when patients were coming through our doors. So we did institute standardized social determinant screening through our EMR vendor. We used a condensed version of the Prepare tool and started that work in 2018. We also implemented the North Carolina Medicaid Transformation social determinant screening tool in preparation of go live of that. And what we have found since starting that work, and we We did prioritize which offices to launch that work, so it is being fully embedded in our community and academic clinics currently. But we built an infrastructure that can be supported across our entire footprint and all of our practices as well as inpatient. And to date, our top 3 social needs have been food, housing, and transportation. And that is actually how we have selected our social determinants from a priority standpoint to put a strategic plan around. So we initially started with food in 2017. And this year we created a strategic plan around housing. So really taking the data that we received and implementing them in new and different ways. One of the things I heard from my colleagues was, fine, you want me to screen for social determinants, but what do I do when someone says, yes, I'm food insecure? So we actually partnered with a vendor called Aunt Bertha to provide a community resource navigation platform. So we're now able to make referrals to community partners when they screen positive on the social determinant questionnaire. We also get a closed loop back to know if the patient receives services, and we're actively working on how to embed that in our clinical workflow and within our EMR. I mentioned that food was our first social determinant that we put a strategy around. One of the things we recognize is that for children who receive free and reduced lunch during the school year, 6 out of 7 of those kids go hungry in the summer. And so we partnered with our food vendors, Sodexo and Morrison, to bring the Kids Eat Free program. We were the first hospital in the state of North Carolina to launch this program. We started off with one hospital, and we looked at multiple variables to figure out which hospitals we should launch this program. And so we looked for hospitals that, one, were located in dark red or dark orange areas, that had public transportation that readily available to our facilities, that had a supportive community infrastructure in place in a volunteer platform to support the work. And so in our first year, one hospital, we served over 3,400 meals in a 10-week period. This past year, we expanded that to one of our rural facilities, and we served over 7,400 meals in 10 weeks. So provided free breakfast and lunch for our children. And they did not have to have any type of filling out of any forms or anything like that. As long as you were 18 and below, you were able to come and receive breakfast and lunch for free. And then again, I mentioned that housing was our second social determinant we selected this year. That did drive our $10 million commitment to affordable housing within Mecklenburg County. We also are partnering with LISC and Fannie Mae to really put a healthy and thriving community infrastructure and checklists in place for the developers who will be coming to the fund to request this funding to build affordable housing units. So different things on that checklist could include preference for having mixed income of housing units. We know hypersegmenting poverty does not work, and so what are some things that we can put in place to protect against that? So really excited about this new strategy for us. And then when you think about partnerships, as I mentioned earlier, as part of our strategic imperative, it's in partnership with others. We have had a multitude of different community partnerships for many, many years, but things to think about that may be considered non-traditional partners. And so Novant Health has historically been considered a competitor to us, and we came together in 2016 after the civil unrest from a police shooting to really say that in the space of community, we should be working together. So we formed the One Charlotte Health Alliance that focuses on 6 public health priority zip code areas within Mecklenburg County. One of the great wins about that so far, we had to hold that mirror up to ourselves and have those uncomfortable conversations even amongst ourselves. And when we first started this work, there was only one primary care office in all of those 6 zip codes. And I always like to say it was the office that I trained at as a resident here at Atrium Health, but there were no urgent cares, and so primary care access was not the greatest, and then we wondered why both of our systems were seeing high rates of unnecessary ED utilizations coming from these zip codes. So to date, there has now been a commitment for 2 additional primary care offices to open up in the 6 public health priority zip codes, one that just opened up this year through a partnership with Novant and Michael Jordan. So many of you may be familiar with the commitment that Michael Jordan made. And that conversation was driven from this work around improving primary care access within the 6 public health priority zip codes. We also have brought 2 mobile units that provide primary care, behavioral health, and dental, specifically, again, within those 6 public health priority zip code areas. So with that, I'm going to turn it over to my colleague, Dr. Coltman, to talk about some of our diversity and health equity work.
Thank you, Dr. Cole. It's fun to present this conversation with Dr. Cole because what she's laid out is how we've tag teamed on our system health equity strategy. She's been out in the community impacting social determinants of health, and so what I'll talk to you about is really the inside strategy around how we've built out the infrastructure around health equity. But I'll start by bringing you back to our system mission, and if you'll recall, the very last part of our mission statement is the words for all. And when we revamped our mission statement recently, it made sense to use that as the rallying cry for our diversity, inclusion, equity work. And so this is actually the picture representation of our diversity and inclusion agenda. So we have bodies of work that follow for patients, and then teammates, and then also community. And so I'll walk you through mainly the work around patients. As many of you know, though, Atrium Health is the signer of what's very familiar to this audience, I'm sure, the American Hospital Association's Equity of Care Pledge, and of course that has 4 different goal areas. I'll spend the rest of our conversation today highlighting our work around Goal 1, but it feels right to mention that we've also had an active body of work around Goals 2, Goals 3, and Dr. Cole really walked you through a lot of pieces under Goal 4, which are far beyond the One Charlotte Health Alliance, but that is certainly a part of it. I'll mention briefly, though, around Goal 2, for many, many years, we've had a very robust diversity and inclusion agenda focused on the workforce, and specifically educating the workforce. We've had what's historically been called the Diversity Symposium that has been in place for many years. And we are actually in the process of taking that conversation national. There will be an invitation that we'll be sharing with a lot of partners to attend our For All conference, where we'll be sharing conversations nationally around diversity, inclusion, health equity. And so we have about 1,300 plus of our teammates that attend this annually, and it's really our way of planting seeds across the system. We also have a diversity certificate program that's cohort style. We build those cohorts very carefully to reflect the diversity of the teammate population in every sense of the word, diversity meaning geographically, racially and ethnically, gender-wise, sexual orientation, job function. So we really build these mosaics that are the cohorts for the diversity certificate program, and then those folks go back out into the workforce and really become seeds of change around continuing our conversations around diversity, inclusion, equity. So I share that with you as part of our Goal 2 strategy. We've made an intentional commitment not to do the one-size-fits-all cultural competency education. In addition to the programs that I mentioned, we also have an entire strategy built around how are we going to bring education to our physicians and advanced care providers, our registered nurses, other many folks in the allied health professions, and then also our patient-facing teammates who are in non-clinical roles, such as food services, environmental services, and other areas that are interacting with patients on a daily basis that may or may not actually be providing clinical care. So we've worked on that across the system. And then we've also looked at our social contract with our communities is what I call our work around diversity and leadership governance. Our board is actually very reflective of the diversity of our community, and we've been working hard, like a lot of other healthcare organizations across the country, to shore that up in our senior leadership. This has been a goal area that's been very important to our CEO, Jean Woods, to focus on how are we going to diversify our leadership team that reflects the diversity in our workforce. And so we've built diversity pipeline programs. I won't spend time beyond that on that today, but it feels right to convey that this is the work around Goal 1 is just part of an overarching strategy. So let's talk about the notion of collecting better data. As over the years when I've had conversations with physicians and other clinicians about health equity, and you talk about different disparities in care, immediately the conversation will shift to, well, I'm not sure if I trust the data. The way that we even identify patients from a race and ethnicity standpoint, sometimes the registrars are just looking at the patients and not actually asking them. And of course, those issues were certainly present at Atrium Health. And so over the course of 2018, we went through a massive planning process that culminated in January of 2019. And it was around the notion of collecting better data from our patients across a variety of demographic factors. When we started the conversation, we only were collecting the Office of Management and Budget, more generic race and ethnicity categories. We're all familiar with them. It's black, white, Asian, etc. And we wanted to create the capacity for patients to be much more granular in terms of telling us who and how they see themselves as, rather than forcing patients to identify with a big bucket category that may or may not align with how they see themselves. And so we went through a very painstaking process of analyzing our own census data to understand which patient populations were existing in our communities served. And then we looked at the options that were available to us, which there's over close to 1,000 different race and ethnicity options that the federal government will allow you to select from in your EMRs in order to be compliant with an entity called the Office of National Coordinator. So we selected, and as many of you know, you have to select them as separate categories in order to be compliant with meaningful use standards. So we selected 28 ethnicity categories and over 40 race options. We added the ability to multi-select for our patients. So if a particular patient says, well, my mom's African American and my dad is white, then we wanted to be able to tell that story in our data. We eliminated other as an option when we embarked on this journey. Over 12% of our patients were listed as other in the system, and if you sort of do deep dives into the why behind it, it was often the case that patients just didn't identify with the categories that we had available. We also vastly expanded our language options. We made that a hard stop so that it was clear to our registrars we needed that patient, even if the patient speaks English, even if that's not the trigger to cause an interpreter to be dispatched. We still wanted to know the language of our patients and whether or not they needed to work with interpreters, because that helps us on the back end with population health analyses to understand which patients may be at risk for certain, as many of you know, in the literature, there's lots of indications to suggest that if a patient is limited English proficient, he or she is much more likely to have communication problems in inpatient and outpatient settings. He or she is more at risk for medical errors, for delays in care. So we really wanted to be able to monitor for that, hence the hard stop in our EMRs. We also added sexual orientation, gender identity data collection. We have that on the front end, so patients can actually For example, transgender patients can let the registrars know that there is a different category between their sex observed or assigned at birth and their current sex. And then we also have very robust sexual orientation and gender identity data collection capabilities in the medical part of the record when our patients are with providers. So all of that to say that we went through a very long process around rebuilding and designing the electronic medical record system to accommodate these new data collection capacities. But then we also needed to educate registrars to collect the data well and in a compassionate and culturally sensitive way. And we also wanted to speak directly to our teammates about why we were collecting these data and also to patients in the community at large. So as you can see here, we created job aids for our patients, for our teammates in registration so that they had very careful scripting around all of the questions that patients may ask when given the question, what is your race or ethnicity? And we heard feedback from our teammates in registration roles, this is really uncomfortable. I don't know what to say back if they say this or that. And so we did a lot of work with the leadership of our kind of business office functions to make sure that we were understanding what the sensitivities were, what they were hearing from patients as concerns, what they were hearing from teammates in those roles concerns. We designed an e-learning that we launched and assigned to every single teammate in a patient registration role, and then we worked with leadership to help do role plays, to develop frequently asked questions, and the e-learning that we designed actually runs the participant through all kinds of scenarios. What if the patient says, well, I'm American, which is, by the way, not exactly one of the categories, or if they say, I took 23andMe and now I have 12 different categories. What do they say to that? So those are some of the things that we had to walk through and think through ourselves. What is the right answer to say to patients when these difficult questions are asked? We also had to go through a process of mapping all of those categories back in, which I'll talk to you about in a moment. This is the patient-facing materials that we developed. We worked with our colleagues in marketing and communications so that we had very kind of clear, easy-to-understand communication around what were these categories, but more importantly, why are we asking them? And we actually had communications for community leaders if we needed it, if folks asked, but we really wanted to speak directly to patients to make sure that they understood the rationale behind it, because we recognize that sometimes some patients may experience this as a rather invasive question. So if you go through all of that process of making sure that the data that you're collecting is good, and by the way, once we went through that journey, so we went live with this new data collection methodology in mid-January of 2019. Since that time, we've had well over 100,000 patients who had been identified as other in our race ethnicity data actually convert to accurate race and ethnicity data categories. So, and we've seen movement across the board. We've seen, pretty much all of the major racial and ethnic categories pick up some patients as a result of that. But when we blew out that many categories, we also had to map them back into the larger big bucket categories for analysis purposes. But we also have the ability to do that drill down into subcategories. So if we're trying to understand a particular dynamic or a particular disparity in a patient population, then we have the ability to understand, well, is this newly immigrated patients who are from Guatemala who are limited English proficient, or is it patients who are from Cuba, blah, blah. So we can do those drill downs if we need to understand the nuance to a particular dynamic in care. So all of those get mapped to what we call our demographic data wall. It is an in-house health equity analytics platform. It allows us to stratify all kinds of clinical measures by race, ethnicity, gender, and drill down by location. I should also add that we are adding the ability, will probably be done by the end of the year, we're adding the capability of being able to stratify by limited English proficiency, because as I mentioned earlier, we know that that's a risk factor, and we know that the literature points to the idea that patients who are limited English proficient may experience disparities in care, so we really want to monitor for that so that we can intervene as needed. So this is a tool that helps us look across the enterprise, and it, as we integrate with new health systems down the line, it's not completely seamless, but relatively seamless process of starting to flow their data into this in-house platform. So we look at all kinds of inpatient metrics. We can look at, for example, at readmissions, but we can also disease stratify readmissions. We have all kinds of population health metrics loaded into the system, breast cancer screening, cervical cancer screening. We can look at A1C. We can look at diabetes, blood pressure control. So all kinds of things. Core measures are in there. We just added infant mortality recently, and the great thing about that addition is that we were able to identify a gap in how we were collecting race and ethnicity data on newborns. So we're going to be working in 2020 to make sure that we're collecting just as accurate data there. But another thing that I want to highlight that's been really important to us is to understand just our general patient demographics. So what patient populations are flowing where throughout our system and why? When you think about what Dr. Cole mentioned earlier about the unique dynamics of a rural area versus an urban area, and who's there, and what ways are they utilizing the system, and in what ways are they slipping through the cracks in the system. So I think those are really important questions that we need to continue to tackle as healthcare systems. So using that data platform allowed us to identify a disparity in care that we chose to intervene in. We actually noticed the disparity in the latter part of 2018. Actually, when we first detected the disparity, the colorectal cancer screening rate for Hispanic males was actually more like 60.2%. As an aside, the reason why we began to dig deeper into colorectal cancer screening is a couple reasons. One is there had already been an enormous amount of operational work in general just to expand access to colonoscopy. So a lot of operational efficiencies had been achieved through some very visionary leadership within our GI division. So it felt like the right time to now start to tackle the disparity, because a lot of the just general operational kinks that keep patients from getting in to have a colonoscopy had been worked out of the system, and so we had sometimes access within a week. Within a couple of days, a patient could be scheduled for a colonoscopy, which was very exciting to us. But the other reason was CMS had recently, at the time that we detected it, pushed out some information really encouraging health systems to both race and gender stratify their metrics, particularly around colorectal cancer screening, that there was national patterns in this area, and we saw that here. And then if you dive into the literature around understanding, are there cultural reasons why Hispanic Latino males uniquely may be not being screened at the same rates? There is evidence in the literature to suggest that that may be true, and so we wanted to be able to see what our interventions locally could do to influence this outcome. This was a partnership between the Office of Diversity and Inclusion and Community Health. This was a really great collaborative because Community Health, Dr. Cole's division, has so many wonderful assets around data analysis, but also linking back to the bedside and being able to understand what's happening operationally that may be causing patients to not get screened at the same rates. And we unearthed all kinds of things that were surprises to us. We unearthed the idea that, we assumed that certain materials were going to patient households in the correct language. So we assumed that Spanish-speaking patients were receiving Spanish-speaking materials. But we detected several instances where that was not happening. So we had to work to get those materials translated, make sure that we were tying the language of the patient back to the materials being sent home. So just little things like that. But the biggest victory was a very assertive call campaign to be able to reach out to patients. Over 200 patients were, hundreds of patients have been called, and over 200 additional patients were screened. For patients that declined the colonoscopy, they were referred to their primary care provider to have fit tests, and then, of course, we're working on that continually. Actually, the number continues to climb as a result of these efforts, so we're very proud of that. But it feels right to share that, all of this at the end of the day is individual patients. And so as we intervene and we have these interventions with the particular patient population, this is a actually de-identified real patient situation where through these efforts a patient was identified, had the colonoscopy, polyps were detected that were too large to be removed during the colonoscopy. They had to be removed surgically. But this is another example of a patient who's going to be able to go home to his family, to live a healthy life, to be a provider, breadwinner, to be a father and grandfather. So I think it's also important when we talk about kind of the big data around this that we're also bringing it back home to this is individual patients' lives. We've also done a lot of work around around language access. We have realized that we have a decentralized language access model, and that we need to make sure that we are finding ways to bring economies of scale as we grow, but also addressing any kind of challenges in how we're running the department. We had a decentralized language services model, meaning that each home department had the decision rights around whether or not an interpreter was needed in that area and how it was going to be paid, and the cost of that interpreting service actually hit that home department. And as you might imagine, that creates a lot of inefficiencies across the system, but it also can be a barrier to care when you're not bringing the right resource to the right area. So we are actually in the process of sweeping all of that under one umbrella. We're doubling down on virtual access to interpreters. We are adding significant amount of in-house interpreters so that we can move away from agency volume. We're also looking at other ways to make our services and facilities more accessible through, creating a centralized, very visible document translation repository. We're developing multilingual wayfinding standards for our facilities that will be kind of cookie cutter across the system. And we're also creating incentives to hire more bilingual teammates, because we know that it's not always the best solution to use interpreters, that sometimes the best solution is to have bilingual teammates that are fluent in patients' native languages at the bedside, ready to communicate directly with patients. Just a couple more things before I wrap up and we entertain questions. I do want to highlight some other work that we've been looking at, a whole LGBTQ plus care strategy for the system. We are hoping to do big things in 2020 around this strategy, looking at building out kind of nationally recognized model. In the meantime, in the second quarter of this year, we launched Levine's Children's Center for Gender Health. The leadership of our pediatric care team realized that there were gaps in terms of how families of transgender and gender non-binary children were being navigated through our system, and this was really their solution, which I love. It's exciting because they're bringing a multidisciplinary approach and wrapping all around patients and families in a very supportive and holistic way. So we're very excited about the launch of that center this year. And as I close out my section of the presentation, when you look at Dr. Cole's map and you look at the parts of the community that have been systematically excluded from a lot of upgrowth and economic, revitalization in communities, as big healthcare systems, we have a tremendous, I believe, opportunity and responsibility to think about all of the ways, all of the tools that we have to deploy in service to, supporting economic empowerment within the communities that we serve, because those are ultimately health outcomes that will be influenced as a result. Part of that is how we employ people in our communities, but it's also how we spend money in our communities. So we have rebooted our supplier diversity work this year. We have a new leader who is breathing new life into it. We're looking at very intentional strategies so that we can those same zip codes that Dr. Cole highlighted, we're looking at what businesses exist in those communities and how can we connect and do business with them. I'm very excited about this because I think it's a whole new way of thinking about social determinants of health, but it's also flexing a different muscle for us as a system. We've had a supplier diversity initiative in place for a long time, but we've really kicked it into high gear this year, and I'm very excited about that. So at this point, I'm going to pass the baton back over to Derek so that he can guide us through the Q&A section.
All right. And thank you so much. As a reminder, you can submit questions by typing in the question and answer box on your screen and clicking Submit Questions. And we actually have our first question. Which EMR system do you use at Atrium Health?
Dr. Cole, you want to take that one?
Yes. So in our primary enterprise, we primarily use Cerner, but we do have other partner facilities that are on Epic as well. So we use both of the two most widely used platforms in the country.
Excellent. Our next question is can you tell us more about the Men's Diversity Leadership Program?
Sure, I can take that one. So this is Dr. Coltman. I will say that I like to talk about that in the broader context of diversity pipeline programs. So we have, and I didn't talk about this at the beginning of the presentation, we have 8 system resource groups across the system, or other organizations will call them employee resource groups, and they have been really phenomenal at highlighting our opportunities for improvement around patient issues, but also teammate issues. And I think they've been good partners in helping us think about how we honor that commitment to diversify leadership at the top. So for many, many years we have had and continue to have a women's executive leadership group, which is a system resource group, and they were highlighting and calling attention to the need for the health system to be more intentional about growing and grooming women leaders. And so there were cohorts formed for the women's executive group. It was a diverse group of women, racially and ethnically. It's a cohort style. We've run 2 cohorts of that. They have been, they go through a very intensive kind of self-efficacy professional development program. These are already, the women selected for these programs are already considered kind of high potential, high performing leaders in the system and kind of poised and ready for growth. They were matched with executive sponsors throughout the system that were in senior leadership roles, most of whom, incidentally, were white males. And so we've seen a lot of success and growth of the careers of the women that participated in those programs. However, we have a different system resource group, the Men's Diversity Leadership Network, that is comprised primarily of men of color who are in leadership roles. And they, came to leadership at the time and said, you know what, we're having challenges too in growing, and we're part of the diversity story of how you grow diversity at the top. And so they we created a program for men of color. That's the Men's Diversity Leadership Network. The Men's Diversity Leadership Development Program. We actually selected all men who were in director, assistant vice president, VP, and SVP roles who were men of color into that program, we also ran a couple of cohorts too, very similar kind of curriculum and content, and then also had executive sponsors.
Excellent. I think we'll take one more question, and for those who asked a question, we have a list of your questions, and we can get back to you via email. For our final question is, how are bilingual staff trained to be interpreters, and are they solely interpreters, or are they serving in a clinical role as well?
So I will say I will differentiate between bilingual staff and interpreters. So we have, as I mentioned earlier, a very robust, we're actually changing the name of language services to the language access because we feel like that's more honoring the spirit of what we're working toward is language access. So that is the paid interpreters who work for the system, who are trained and qualified, and many of whom are certified as interpreters by national certification bodies. What I was referring to is a bilingual teammate program. So that's not actually trying to put, for example, a nurse who will also function as an interpreter for other folks. That's actually trying to put that bilingual nurse in a position where he or she can communicate directly with a patient. From an operational standpoint, I think there's pros and cons to having kind of dual role interpreters where they're a nurse and also kind of get pulled in as an interpreter from time to time. I think the dilemma around that is sometimes that they don't, because you're not interpreting every day, just like you want, if you are getting an IV, you want a person putting in your IV that does that every day, and their clinical skills are sharp and strong. And I think the same is true for interpreters. You want to have professional interpreters that are doing it day in and day out and are very skillful at moving from one language to the next. What we're trying to do is put more bilingual folks at the bedside so that they can communicate directly with patients without having to use an interpreter.
Excellent. Thank you so much. And again, for those of you that have additional questions, we will follow up with you via email. But for now, this has been a wonderful and very informative session, and I would like to thank Dr. Coltman and Dr. Cole for sharing your expertise with our audience. And you will be able to access today's recording in about 2 weeks on the Institute for Diversity's webpage. And to stay connected and up to date to IFDHE's latest reports and webinars, please follow us on Twitter. Our next webinar will highlight the Carol Boone Lewis Equity of Care honoree from Norwell Health in New York, and you can see information about that on your screen now. And finally, we would like to ask each of you to take a moment to complete our evaluation form. You will see a link on your screen, and if you click that link, you'll be taken to an online survey, which will open in a separate tab. We hope you take this opportunity to evaluate us and help us understand what is working well and what will be most beneficial to you. And with that, again, I would like to thank Dr. Coltman and Dr. Cole, and I hope all of you have a great rest of the day.
Thank you, ladies and gentlemen. This concludes today's teleconference and webinar. You may disconnect from your phone and log off. Please enjoy the rest of your day.